Top Bed Talk.
Thank you very much for asking me to present today on prehabilitation for people with cancer. My name's June Davis, and over the next 20 minutes I'm going to talk to you about the prehabilitation in cancer guidance that was developed and published in 2019 following significant evidence-based review and a Delphi process and recommendations for taking prehabilitation for those with cancer forward, both within the UK and internationally. Certainly the guidance has been extremely well received across the UK and internationally, and I will take you through some of the headlines over the next 20 minutes. Just to give some context in terms of national policy, prehabilitation across the UK is gaining significant momentum across the system and has been integrated into a number of policy and strategy documents, in particular personalised care and the desire from an NHS England point of view to ensure that all patients, participants have personalised care embedded into everyday NHS services. The work around streamlining multidisciplinary team meetings for cancer include the opportunity to discuss the prehabilitation needs of people with cancer and the importance of preparing people in advance and during treatment. And I'll come back to that as we talk through the content of the guidance. The long-term plan for the NHS is critical, and you can see weaved throughout that elements of the principles of prehabilitation, as well as the importance of earlier and faster diagnosis and the importance of us preparing people particularly at the moment as we increase the number of patients going through cancer services, particularly during this pandemic period. Again, a bit more context from a couple of our national healthcare system leaders. Professor Stephen Powis, who's the National Medical Director for NHS England, alluded to the importance of perioperative medicine and prehabilitation before surgery. And Simon Stevens, Chief Executive of NHS England, just on Boxing Day, just after Christmas last year, again was championing the importance of having prehabilitation as part of cancer support for patients going forward. Critical to the development of the guidance was engaging with our service users and those people affected by cancer. And what is clear is that the benefits are significant for people and those that they live and care for them. Three key elements come out: personal empowerment, the importance of physical and psychological resilience, and the importance of long-term health. Just to share with you some really important quotes, which I think should be at the heart of anything we do in the system in terms of supporting patients. Particular one to share there is: prehabilitation helps you pick, edit and contribute to your cancer story, so you have your own ownership and don't just feel you are being done to. Clearly, these are really personal comments and quotes, but we need to think about how we deliver services based on what people tell us, and they're really important to help guide how we deliver services going forward. Just a reminder, but really, really important, is the purpose of prehabilitation in cancer. I think one of the key things is none of us would run a marathon without training, and it's really important in terms of how we empower people with cancer to enhance their own physical and mental health. What we do know from the evidence, and I would touch on this a little bit more, is the benefits can be seen in as little as a 2-week period. So if we are diagnosing people, there is no reason why we cannot start supporting patients with prehabilitation interventions at an early point. What is also critical is that prehabilitation is a continuum to rehabilitation. It's not in isolation. And we need to support people before, during and after treatment, whatever treatment that is. And I think that's key. Prehabilitation is important in advance of any treatment, not just surgery, radiotherapy, chemotherapy, immunotherapy, or any combination of those. And prehabilitation enables people to prepare for treatment, but also help with behaviour change and long-term support around how to be more active, eat well, and be psychologically well. We know the impact of poor physical and mental health on outcomes, both health and psychological outcomes, and prehabilitation helps really support patients to empower them to be able to do and control things for themselves when a lot of their treatment is taken out of their hands at a really vulnerable and anxious time. Just some benefits of prehabilitation. The evidence is increasing in this space. Evidence initially was in the sort of surgical space, but now is increasing around those with chemotherapy and or radiotherapy and or immunotherapy. And the evidence review that we did was over the last 10 years, so it was a fairly comprehensive evidence review, which you can also read if you would like to on the Macmillan website, and the whole spreadsheet is there to view. Reducing length of stay in terms of system outcomes, enhancing recovery following treatment, really, really important. Reducing post-treatment complications, improving cardiorespiratory fitness, improving nutritional status and neurocognitive function, and ultimately enhancing quality of life. In addition, absolutely providing a teachable moment to enable smoking, alcohol cessation, improve general health and well-being. So within the guidance, we have divided the document into overall principles: what prehabilitation looks like in the cancer care pathway, how we develop services, what workforce is required, quality assurance and improvement, and what we need to think about in terms of how we improve and develop services, the clinical leadership and what is required to deliver, and the how we develop the evidence base, because we know the evidence still needs to be developed in some areas. So just thinking about prehabilitation principles for a moment. Prehabilitation enables us to support people to increase and maintain and increase their healthy behaviours. Some of it might be quite simple advice, but actually, even if we can encourage people to do more activity, eat well, etc., that is going to help them going forward. The evidence is very clear, and it helps people perhaps be less vulnerable to the side effects of cancer treatment, and we can also then appropriately target interventions based on how we screen, which I'll come to shortly. How do we integrate prehabilitation into the cancer care pathway? We have suggested in the guidance something like a personalised prehabilitation care plan. We're very aware that people have care plans for all sorts of things, and this does not mean an additional plan, but it needs to be considered as part of discussions with multidisciplinary teams about what the treatment options are for patients, because if they're not fit enough, then actually they could have greater complications and other issues going forward, which doesn't do anybody any good. So what is clear is that we should support people with interventions as soon as possible, and in some cases, and we have examples in some parts of the country where interventions are happening in advance of a confirmed diagnosis. And again, it's about promoting health and well-being, so that's not generally going to do any harm to anybody. Integrating prehabilitation into the cancer pathways. So just thinking about the stages very broadly. So if we look at diagnosis, prehabilitation begins at the point from diagnosis, and in some cases before a confirmed diagnosis, as I've said, aiming to optimise people's health. Pre-treatment assessment, screening for prehabilitation, assessment and a care plan is then included in the prehabilitation care plan, and where a patient's needs are identified, then a prehabilitation programme would be prescribed. Then there may be surgery and or other treatments, and the programme would continue, and depending if somebody has systemic anti-cancer therapy, then they may again be screened, assessed, and the care plan would continue, and that would then continue through treatment and beyond into rehabilitation depending on the patient's needs. And we have outcomes that we would be collecting during this time, and there's discussion in the document about the type of outcomes to be collected. However, I think there is more work to do in that space, and we would be looking at continuing people's rehabilitation going forward, and as they become well. I'm sure many of you have seen variations of this diagram. However, it clearly illustrates the importance of general health increasing if we prehabilitate people and continue with rehabilitation for those that require it throughout the journey, so through diagnosis, treatment, recovery, and those that are living with and beyond cancer. And underneath the diagram, you've got the stages of rehabilitation. It's the Dietz model, and where we look at preventative, restorative, and supportive and palliative care. So it's important that we think of prehabilitation and rehabilitation together, not separate and in isolation. Screening for prehabilitation, I know you will hear about more of this. There was a lot of discussion when we were writing the guidance about screening. However, it's important that we get this right, because we need to identify who needs what, when and where, and what the interventions are best. Validated tools need to be used ideally to then inform what assessment will happen. Just thinking about the assessment, one of the things that we are clear about is that people do need a holistic assessment. There are various holistic needs assessments in the system. However, it's important for us to look not just people's physical and mental well-being, but also other things that might be impacting on their health, such as spiritual, work, finance, housing, other things, because that will impact on how they respond to the support that we give. Just thinking about the prehabilitation interventions in their own right, there are three categories, and many of you will have seen this triangle, which I'm sure will be used many times throughout this event. And we look at universal, targeted and specialist. And people will go up and down, and they will go around this triangle, and it will depend on the type of tumour they have, it will depend on other comorbidities people have, it will depend on a whole range of things. But we need to be mindful that this is a moving triangle rather than static. And what we're suggesting here is that the universal interventions are self-monitored and that people monitor those themselves, and that the targeted specialists are requiring more dedicated support from professionals. And I'm just going to take you through headlines about the nutrition and exercise and psychological interventions, particularly at a targeted and specialist level. Universal is clearer in that it's promoting health and well-being, making every contact count, promoting good physical activity and exercise, advice, nutrition, and emotional support. But when we get to targeted and specialists, people have more targeted needs. So just thinking about nutrition, in terms of targeted, we'd be looking at dietetic counselling, and that would be from dietitians, assessing readiness to change, looking at the goals around nutritional recommendations, how we motivate patients, and the therapeutic dietary advice that would be offered. At a specialist level, and they're people that have extremely complex needs, we'd be looking at artificial nutritional support and or enteral and parenteral nutrition. Thinking about exercise, so just thinking about targeted support for people, we'd be looking at referral and support for appropriate reconditioning, including prehabilitation exercise programs, which would include healthy conversations, making every contact count, of course. That could be group support or one-to-one, and that could be in local community settings and could be run by cancer exercise specialists or other parts of the workforce. And there's more description of the workforce in the guidance. At a specialist level, we would be looking at fully supervised exercise interventions, whether that's aerobic endurance strength, and again, depending on the complexity of patients, that would be a tailored programme. Psychological support and behaviour change interventions. At a targeted level, we'd be looking at psychological techniques such as problem solving, counselling and specific psychological interventions, which might include anxiety management, solution-focused therapy, those kind of things. And at a specialist level, psychological and psychiatric interventions such as psychotherapy, including cognitive behavioural therapy, which again would need specialist support from specialist parts of the workforce. Just thinking about where we've moved in terms of the guidance going forward, there has been a lot of impacts of the guidance and the momentum is significant. There are 3 work streams that have come out of the action plan in the guidance: service development and commissioning. And in there, we are looking at a range of things and including scoping prehabilitation services across the UK to understand the baseline, what's there, where the gaps there are and what we need to do going forward. And also looking at developing commissioning guidance in the prehabilitation space. Looking at workforce, we are actively working with all the relevant professional bodies and other agencies to look at the physical activity and exercise workforce and ensure transparency for the public to be able to be supported, whether it be in a gym setting, a leisure centre, a local community service and or the NHS, and how we ensure seamless transition between services. And we have full engagement from the Professional Standards Authority, who oversee all the regulators of the professionals in that work. The third piece, which is equally significant, is about our quality assurance, quality improvement and research. We know there are a lot of evidence gaps and the research questions are in the back of the guidance that we need to consider going forward. And there are various discussions with organisations such as the National Cancer Research Institute, who have highlighted prehabilitation as a research work stream. We also need to increase the health economics around what we do and how we evidence the vital importance of prehabilitation from an economic perspective. So just very briefly, and I know others at the EBPOM conference will be talking about this. So we have just recently, as a result of the pandemic, and this is a significant collaboration between many partners, Macmillan Cancer Support, University Hospital Southampton and Can Rehab Trust, to set up a remote pilot service. And this is a pilot, and we are offering support through Can Rehab Trust Cancer Exercise Specialists to offer people exercise, basic nutrition and emotional support to maintain and improve physical and mental well-being. And this is for people with cancer at any stage in their pathway. Key things about SafeFit: designed in 8 weeks from nothing, so has been a lot of work by a lot of people, but directly in response to the pandemic. This is a pilot and a trial evaluation. It is absolutely founded on the guidance, so hence the reason to share the principles with you. We're at a really early stage of this service, and we're working through and are testing and reviewing on an ongoing basis how participants, instructors are working, the screening and the assessment processes, but all very exciting. And I guess the USPs for SafeFit are key for this is self-referral. So people self-refer via the Macmillan website. This is testing a new workforce model that we've not used before in the system, like this. Remote delivery of evidence-based, multimodal, universal interventions, and I've talked about universal interventions earlier, and it's critical to this is the evaluation trial. Thank you very much for listening.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.